So some of what I'm going to say is going to be redundant, or let's call it reinforcing, hopefully not in conflict with what you heard from Dr. DeWald, but you know, it's sometimes good to hear things more than once. My name's Jeff Chabot. I am a PhD, not an MD, so I'm not going to talk to you about my personal clinical experience, but fortunately you have you know, some real experts there. I'm going to try to get more into sort of basic definitions, some of the more basic science about what's going on when you're doing these procedures, what's sort of peeking behind the curtain. Okay, a couple disclosures. I'm a founder, director, shareholder of a company called Endo Solutions that develops some of these devices. I have a financial interest in Servos, which sells some of these devices. I also work for Pfizer, but that has no bearing on this presentation. Okay, so the things I'm going to cover today, again, a number of them, all of them, you've heard something about at least. I'm going to start with PRP. I'm going to touch on exosomes and alpha-2 macroglobulin as well. Probably about half of my presentation is going to be focused on marrow. And then finally I want to kind of talk a little bit about thinking about the joint as a complete organ, not as individual tissues that we're trying to treat, but real, and I think that really pulls together a lot of these notions into one sort of cohesive framework. Okay. I'd like to start with this slide here because you know, if you're in the medical community, you may have been following this stuff for much longer. But really, when you think about sort of the general public, and when people start asking about these procedures, I'd say it's in the mid to late 2000s when you started having athletes who would have an injury that would normally sideline them for a year and a half between the surgery and the recovery and so on before they could compete. And in some cases, if they got injured early enough in the season, they were coming back for the playoffs. And this really saying, whoa, if it works for them, could this work for me? And so really built up the public awareness of regenerative procedures in general. So, and a lot of that work, early work, was done with PRP. So how does PRP work? So, okay, when we start off with whole blood, it's going to have a lot of different things into it. And then generally all of these systems are going to function by putting them into a centrifuge, which is going to sort out these things by their relative densities. The red cells are going to go to the bottom. They're going to pack very nicely. There's not really any therapeutic benefit to those. We're going to get rid of those. And what we're going to do is we're going to grab either just sort of this very top layer, which is where your platelets are going to sit, or we might go a little bit deeper to grab some of the leukocytes. And so this is how we're going to prepare the two different types of PRP. Leukocyte poor, which is going to be lots of platelets, not so many cells, or leukocyte rich, which is going to have all of those. And we'll talk in a minute about why you might want one or why you might want the other. Now, when you take this composition and inject it at a site of action, the platelets sort of have a natural stickiness. They're going to accumulate sort of in the site of the injury, and some of the cells too, if you have the leukocytes present. But in any case, the platelets, which contain lots of growth factors, lots of signaling molecules, are going to create this gradient, which is now going to draw in more cells to say, hey, there's an injury here, that's why we're accumulating. You guys need to come here and see what you can do to fix this. Okay? So then cells, which are in many cases going to mobilize from the bone marrow, are going to accumulate at that site, and then they're going to guide the repair. Okay? These cells that are coming in, as Dr. Wald mentioned, we used to call them mesenchymal stem cells. We had a notion, and this notion wasn't that long ago, that these cells in stem cell fashion moved into this place, differentiated, turned into the tissue that was damaged, and that's how you fix things. We know now, we've known for a while, that this is actually not the case. Okay, what they're doing is they're actually guiding these cells, which are normally just sitting there doing their job, they're not proliferating, to proliferate, fill in the damage, repair the damage, and then they just go away. So we changed the name from mesenchymal stem cells to medicinal signaling cells. It was handy because nobody had to change their acronyms. But when we talk about MSCs, okay, and Nico will talk a bit about some of the challenges associated with using the word stem cell when you're describing what you're doing. And you know, a lot of the papers that you'll read, the titles will say stem cells. This is what we're talking about. Okay. So what are the keys for success when you're working with PRP? Okay. So probably the most important thing is the concentration of the platelets and the cells if you're making a leukocyte-rich preparation. So what is the concentration going to be? So the fold concentration, how much you boosted it over the baseline, is going to be basically how much volume did you start with and how much volume did you end with, right? So if you take 100 mils and bring it down to 10 mils, that's a 10x concentration if you recover 100% of the cells. So you're also going to throw this thing in there. So what do I want to do if I want to end up with a high concentration of platelet? I want to start with a good volume. I want to reduce it as much as possible. Now, what you also need to consider is if I'm going to inject into a space that's, say, 5 mils in size, if I bring my things down to 1 mil, I've got a nice concentration in the tube, but as soon as I inject that injury, it's going to dilute into the 5 mils. So when you volume reduce down to about the size of the defect you're going to treat, does not, your benefit to concentrating further is going to be, or reducing your volume further is going to be less. And you want to use a process that's very efficient for capturing the particular cells, the components that you're looking for. And the different parts of the PRP, okay, so the platelets are going to have those anti-inflammatory factors and the signaling molecules to bring in other cells to guide the repair. The leukocytes are more complicated. You're going to have some of those are going to be more sort of pro-inflammatory, but many of them are going to be anti-inflammatory. So it's more complicated to think about, but generally they're going to have much more power to address the injury, right, than just putting in the platelets alone. Okay. What kinds of concentrations do you need? Well, these numbers can be a little bit misleading. So, so this is from a paper. All the references are at the end of the presentation, and the presentation's on your stick. So there's probably two things going on here. So the older you get, the higher concentration you need. But this is fold over baseline, and it's an autologous product, right? So if their platelet counts are a little bit lower, they need more, then those two numbers together, give you these very high ratios here. But this just goes to drive home the point that again, if you want to treat people, especially as they're getting older, you want to have a system that sort of matches all of these things: high yields and good volume reduction. Okay. How do I know if I want leukocyte poor or leukocyte rich? Okay, so this is kind of just some general concepts here, and these guys can give you the specific examples that they've encountered. But so we're really going to talk about leveraging the strong anti-inflammatory properties here and the stronger sort of healing properties here. So if I'm dealing with acute pain management, leukocyte poor PRP may be great. If I have an injury and I need to actually call in more of those cells to get the repair, I want to really give it a jump start, consider the leukocyte rich. Older patients, often their problem is chronic inflammation. So again, the anti-inflammatory leukocyte poor PRP is going to do great. In younger people, if they're coming to see you, it's probably because they have an injury. And so again, leukocyte rich might work there. Joint damage, sometimes we don't want to be injecting all these cells directly into the joint. Leukocyte poor might work great. But if you're dealing outside the joint, leukocyte rich may be the way to go. So these are just some general buckets. There's going to be exceptions for all of these cases. But there's always going to be one key idea that to focus on, right, which is the dose and the concentration. Those are the things that are going to wind up mattering for giving yourself the best chance for success for you and your patients. Okay. Going to jump tracks here and talk about exosomes for a minute. So cells have multiple ways to communicate with each other, right? They can secrete proteins. They can be receptors. We call one a ligand, but they're actually both receptors that can touch each other on the surface of the cells as a way of signaling. And what has been coming under more and more interest and focus is exosomes. So an exosome, here we go, is basically just a little packet of what's inside the what they call the donor cell. Okay, so this has things that the cell can't easily secrete, and this could be intracellular proteins. They could be oligonucleotides, RNAs, regulatory RNAs, microRNAs, mRNAs. The lipids themselves that comprise the package. There could be carbohydrates, lots of different things that this cell can bundle up and then ship out, where it can basically fuse with the next cell over, drop those things inside, and in that way help to steer the host or the recipient cell. So, if the cells that are producing this, now we can think about two different cases. So within your body, when you're having natural healing, these MSCs move into the site of the injury, size up what's going on, and they start sending very specific messages related to that particular injury to tell those particular cells what to do. If we just want to talk about preparing exosomes, okay, what message you're getting from those is basically what is the baseline message that the cells were sending. So people did a lot of work looking at exosomes produced by cells from all over, from dental pulp, from bone marrow or adipose MSCs, amniotic fluid, okay, people were, because that's a very sort of anti-inflammatory environment, right, in utero. So if you take exosomes that those cells are just sort of naturally putting out, they're going to have a good, strong anti-inflammatory profile. However, as was mentioned, the FDA heavily restricts these to the point where there are no approved exogenous exosome products that are out there. And so there was a lot of hope for these things, and then the FDA basically said no. However, you can make exosomes, prepare exosomes from the patient's own tissues and deliver them back to the patient. That's fine. And we've heard about a couple of ways to do that. We're going to have a demo in about an hour on how one of these works. Okay, so if you prepare your exosomes from PRP, well, we're kind of in luck. So exosomes in circulation tend to have a really strong anti-inflammatory profile, okay, especially as you concentrate these things down. So the way I like to think of this is your body has sort of a basal anti-inflammatory tone, okay, so that if you get inflammation here as those cytokines, chemokines, whatever, spread through the body, you don't suddenly have global inflammation all the way across your body. So if we think of it, here's, representation of the body sort of across this line here, you have this basal anti-inflammatory tone. So when you have an injury, and you can get inflammation, but only at that site, and everywhere else that signal is suppressed. Okay, so the cells know where they need to go in order to fix this. So what we're going to do is we're going to take this sort of basal tone, concentrate it, and deliver it just where we want it to be, just where we want to shut down this inflammation. So when we do this, now all of a sudden, we've boosted the suppression here, so now we can tamp down inflammation. Okay. And the exit here. Okay. Alpha-2 macroglobulin, similar concept to the exosomes. So as was previously mentioned, it's a really huge protein, 720 kilodaltons. It kind of looks like 4 mittens, and the mitten's a good analogy. So contained within the mitten is a short little sequence that various proteases that can degrade extracellular matrix. Okay, so things like your RMTI proteins, matrix metalloproteinases, they love this thing. It looks very attractive to them. So when they come in and they grab it, it's called a bait sequence for exactly the reason. It baits the protease to coming in, then the mitten goes and grabs it. Okay? And now that protease can't do its job. So if you're trying to prevent ECM degradation, this is a great way to go. A2M can also bind cytokines, hormones, other enzymes. It may modulate how complement works. Those aspects of it are still being sort of fleshed out to fully understand their roles. But sort of by analogy with the exosomes, okay, so when you have these A2Ms that are present in circulation or in a tissue, they're basically keeping that ECM degradation tamped down. Unless there's an injury and these things start going up, these MMPs and MTSs, okay? Now you can start degrading the tissue. So what do? We concentrate the A2M, deliver it to the site of injury, and now we can tamp down even those larger signals, prevent further degradation, and now hopefully shift into a remodeling phase and allow for tissue repair. What I just said. Okay. So I'm going to now shift over to bone marrow. So whereas PRP is largely a growth factor driven thing and a signaling molecule driven treatment, marrow, when you use marrow, instead of using PRP to call cells in, you're delivering the cells directly. Okay, so it's kind of the next step up. And the cells that you're pulling out of the bone marrow, a lot of these MSCs, are going to do things like release cytokines and with the cell-to-cell contact, exosomes, They're going to guide the cells at the site of repair in order to shift from an inflammatory phase to proliferation, remodeling, repair, healing of the injury. Just like with PRP, if you're going to treat with marrow, it's going to be dependent on the dose of the cells that you're giving. You've given it specifically the cells that are doing the work. And then the other things are basically just repeating what I just said. So talking about dose, how many cells do we need? So here's a handful of studies where they looked at patients who had a bone marrow treatment for various conditions. They were nice enough to characterize the bone marrow before they delivered it and say, how many of these CFUFs, which is still kind of the standard for saying how many cells do you have. So you take some of your bone marrow, you streak it out, you see how many colonies grow. So it's cells that have proliferative potential. These tend to be the MSCs. And so in these studies here, they've looked at patients sometime later, split them into successful procedures and non-successful, and said, what's the difference? And there's a clear pattern, okay, that the more of these cells you have, the more likely you are to have success. The fewer you are, the more likely it is to fail. Everybody has slightly different ways of doing this, so numbers kind of shift around. But there is this clear pattern that more cells are associated with better outcomes. The downside is, if you just do a traditional marrow aspiration, so you stick a needle, usually into the hip, and withdraw 40, 50 cc's, you're not going to get the types of counts at the baseline that are going to put you in this column. You're going to be over here. So, just like with PRP, how do we concentrate cells? Yes?
Positive clinical outcomes, pain relief?
Depends on the study, right? So this was a spine fusion, right? So did the fusion take or not? Other studies were on pain management. So, but the pattern that you need to at least have a certain number of cells, held across all the different sort of outcomes, indications. So if your starting cells are not sufficient, we can throw them in a centrifuge, concentrate them down. These centrifuge systems are very clever because just like with PRP, the cells you want are in the middle. You don't want the red cells. The platelet-poor plasma that you get up at the top is not going to be that helpful. So in these systems here, you could go from these few hundred cells up into the range where now you're talking, okay? You're 1,000 cells or more per mil of these CFUFs. So you can increase your concentration 2 to 4-fold. That's great. But part of the problem is that you lose a lot of cells, 56% yield, 39% yield, okay? So you've done a good job reducing the volume, that's giving you concentration, but you went through a lot of trouble to pull out these cells and you threw half of them away. Part of the reason for this is, remember, we're talking about cells that have proliferative potential. That means they're going to be, when I just grab a handful of them, they're going to be at all sort of different stages of the cell cycle. And depending on where you are, that changes your density, right? So a lot of cells end up in the red cell layer. You don't want to keep all the red cells, but now you're throwing away those cells that are at the wrong stage. And one of the things I like to say is, healing is a function of the cells you have, not of the density of the cells you have. It's nice when those things correlate, but it doesn't always have to be. Okay. There's other things, I'll hit this one really quickly, that you have in bone marrow. There's other types of cells. One that I like to talk about is megakaryocytes. So megakaryocytes are the factories that produce platelets. A single megakaryocyte can produce something like 1 million platelets. Okay? These cells are uniquely found in the bone marrow. Okay, so imagine if you have 1 megakaryocyte, that's the same number of growth factors as 1 million platelets. With this paper, I'm just going to skip this really quickly. What they showed is that the MSCs have different properties when they can maintain contact with cells like megakaryocytes that they lose when you separate them, either mechanically or by running through a filter or what have you. So your cells potentially have more power if they're not isolated, if they're really in a milieu that keeps them happy. Okay. One thing when you're dealing with marrow or even PRP, right, is depending on how you prepare it, there could be some red cell content. Is this bad if there's red cells and you're going to go and treat, say, a joint, right? we know if somebody has hemophilia and they have repeated incidents of bleeding into their joints over the course of their life, they're going to have a lot of joint degradation from the oxidative stress and so on. So I'm going to do a procedure and I'm going to inject into a knee, and there's a little bit of red cells there. Is this a problem? So this was a nice paper. It was a canine model where they took a dog, and on one side they injected either whole blood or plasma or just saline, and they looked and then the contralateral joint that just got saline. And what you can see across this thing, and then they did this once a week for many weeks, and you can see like every separation from the saline is bad. Okay, their guarding score goes up. They can't put weight on it. Yeah, this is the contralateral joint, which is why there's no change, right? Their pain threshold goes down. So this is bad, okay? But in the same paper, they also did just a single injection, thank you, to see what would happen. And what they noticed is that after you do a single injection, yeah, there is some separation, but the statistically meaningful separation like goes away. And this makes all the sense in the world, right? Everybody's banged their knee at some point, probably had a little bit of bleeding in there. If banging your knee once meant your knee was shot, none of us would have knees, right? So if you're thinking about doing a procedure, you know, if you're talking about a one-time injection, even if there's some red cell, you should probably try to reduce them as much as possible. But if there are some red cells, don't feel like you're automatically going to be destroying the person's joint. From the paper, what I just said. Okay. And here's kind of another illustration. So this is a full thickness cartilage defect that was introduced in a horse. Okay. And you know, for a long time, the way you treated a cartilage defect was with microfracture. Now we have this nifty laser you're going to see this afternoon. But so what they do, they introduce this defect, and then they basically drill holes into the bone. Okay, this is going to allow cells that are in the marrow to sort of access the space and maybe see if they can do some help. So you know, and that's some improvement over the defect that was introduced. This was if they did microfracture and also injected marrow on top of the space. Now, there's more red cells here than here, right? Because you've got whatever leaked in from the marrow, but here you're also delivering some red cells there. But you can see the healing is better. Why? Because there's more cells that are doing the work here. That trumps the extra red cells that happen to be present. Okay? So it's always the cellular content of what you're putting in there that matters. Okay. There's some questions about, are red blood cells toxic to MSCs? I've gotten this question a few times, so I threw some slides in there. If you extract bone marrow, culture it with different levels of red cells, and then plate it out and look at what you see, the more red cells you have in your preparation, the fewer MSCs, or the fewer CFUFs that you see on the plate after a length of time. So is this bad? Well, we have to understand the difference between an MSC in your body and an MSC differentiating into a colony-forming unit on a plate, okay? So when you pull MSCs out of marrow or out of adipose, they immediately start undergoing changes. They're not in that environment that keeps them in their sort of native state. Their morphology changes, their size changes, the genes that they express change, okay? Basically, they're differentiating into fibroblasts. And when we talk about these CFUs, we say it's actually CFUFs, colony-forming unit dash fibroblasts, okay? So these MSCs that are wonderful when they're in that state, now they're just fibroblasts. And they look like fibroblasts. MSCs look like balls. This looks like fibroblasts. Red cells are known to elicit effects on fibroblasts. They impair their proliferation. They cause increased production of procollagen. So basically, the assay that says, oh, that the red cells are toxic to MSCs is completely an artifact of how you did the experiment. And logically, the MSCs have to tolerate the presence of red cells. Red cells originate in the bone marrow, right? That's where they're created. So you wouldn't have MSCs if they couldn't handle being around red cells. Okay.
So is it,
Yep.
is it actually iron issue, or is it actually red blood cell issue? Because you have lyse cells there in your preparation. It could be a toxic, right? So
Yeah, I think the thinking is that it's well, it's related, I think, to oxidative stress that comes from some of these cells, lysing, basically. Yeah. So, all right, I think I've been told that I'm running late. Okay, so let me skip ahead, okay. All right, there's better ways to get your bone marrow, summary, than using it, pulling out 50 mils, concentrating it, and throwing away half of what you collected. There's bone marrow needles that, through very clever technology, that disclosure I had a hand in inventing, enable you to draw a smaller sample, but where you're getting very high counts to the point where you don't need to use a centrifuge. It's a smaller draw, and you can treat right away. You don't need to put it in, spend extra time processing. And you get great CFUs that line up with that, that range that we said is associated with healing. Very good. There'll be a demonstration of this particular tool in the labs this afternoon. Okay. Marrow in the body. Okay. So can I get, a lot of my patients are older, can I use bone marrow from them? So when you're born, all of your bones are chock full of what we call red marrow. That's very high in these MSCs. As you get older, and you don't need to be very old, like even in say your early 20s, the marrow has basically retreated to the axial skeleton. Pelvis, still great. Okay, iliac crest, a great place to go for bone marrow. You can get bone marrow in small amounts out of the vertebrae. You can get it out of the sternum. I've not heard of anybody collecting it from the skull, but in principle you could. Don't recommend it. And the rest of these bones are not full of red marrow anymore. Now they're full of what we call yellow marrow, which is mostly fat. Okay? There is some blood in there, so if you did a draw, it'll look red. It won't look yellow, but you're not going to get the MSCs that you're looking for. Okay? And the reason that I want to show this is because, when we start talking about joint degradation, it's in joints where the marrow has retreated away from, the red marrow has retreated away from the joint. Okay? So this lines up with where you might start seeing, people who are having these injuries. We don't often see, degraded knees in 4-year-olds. Okay. When you look within the iliac crest of the pelvis, counts do reduce as you get older. It's kind of a weird way this axis is. But if we're saying I want 1,000 or more cells per CFUs per mil, you can get that even from people who are up, pushing 80 years old, maybe even beyond. They just didn't have those people in the study. Okay, this was collected using that knee. I think this is the last thing I'm going to hit on. So when I first heard about this, my brain, I'm not a clinician, sort of said, how does this, what? So you have degraded knees. They're going to go and inject marrow into the bone, into the marrow space. Isn't there already marrow there? Yes, but it's the wrong marrow. It's the yellow marrow. Okay. So this was a lot of the early pioneering work was done by Dr. Hernigou in France, and because he did this then, he could follow people for a very long time. So this was a study that he did, many years ago, but now he's looking at people following average of 12 years follow-up. So what he's done is he's done a knee replacement on one side, and he's injected bone marrow into the subchondrally on the other, and then follows people what happened to them. Just sort of summarizing. Of the knees that were replaced, 6 out of 30 needed more work, within this average of 12-year period. Only one knee that got the marrow injection needed further work. So that's true. It's a much less invasive procedure than chopping out and replacing the knee. And they had more durable results over, say, 12 years. And ultimately, 21 patients said that they preferred the knee that had gotten the cell therapy to the one that had the replacement. That's a pretty strong testimonial. And so why does this work? Well, if we think of the joint not as a bone and some cartilage and a synovial space, but as a complete organ, and say this organ is missing something, it's missing the marrow. When you put the marrow back, the organ behaves better. Okay? And here's one more study. Unlike the previous study, which was sort of all comers, this was exclusively older age people. And in this case, they actually injected on both sides, the tibia and the femur. But again, very similar results when you look at this. When you got the therapy, you had no increased risk of needing a knee replacement than if you looked at a joint that didn't get an injection at all. So really, it's doing no harm, and it's really offered some people some help. Okay, so thanks. There's like 4 slides of references here, everything that I showed in the talk. You can peruse them at your leisure. So thank you.